So welcome everyone to the webinar series on preventing overdiagnosis. Unfortunately, the Oxford event had to be cancelled this year because of for obvious reasons, because of the pandemic. But we have held instead a series of webinars. For next year, we hope to have a preventing overdiagnosis in Calgary. We'll be the next holders of it. So it was great to see the couple of vaccines that are promising, and hopefully everyone will come vaccinated to Calgary next year. But in the meantime, we have a very good day for you today, an hour-and-a-half session where we will go through learning from the pandemic. Can COVID-19 help us build a better healthcare system? I just wanted to quickly go through a little bit of housekeeping for today's session. First thing is we will be recording this and it will be shared after the event. So if your internet drops out or it's very early in the morning there for you, you may look forward to getting, if you've registered, a notification about the sharing of the event, but it'll also go up on the Wiser Healthcare site. Just to note that your video for the attendees and your video and sound won't be turned on during this event, and that the chat function is also off. But we do want this to be interactive. So the question and answer function, which you should see as a button at the bottom of your screen, is operational. Please use it throughout the presentations. So we will be carefully monitoring any questions that come in. It's a good idea to put them in as you think of them. Otherwise, firstly, you might forget them, but it also allows us to see how many questions have come up and select similar questions to merge together. So please do it, as I say, throughout the session. The questions will be asked anonymously, so you're allowed to ask any questions you like, and all of that Q&A will be captured, even if we're not able to answer it during the session, and so we will be able to post that. So the program for today is that, first of all, we'll start with two speakers, Ray Moynihan and Anne Duggan. They will give 10-minute presentations each with 5 minutes afterwards for a question and answer session. So as I just said, please post those questions in the Q&A section as we go along, and we'll come to them after each of the speakers. We'll then move on to a panel session, and we'll have one slide each for each of the 5 speakers that we will have for the panel session to introduce their area and work related to the theme of today. We'll then have about half an hour at the end of that for a discussion with everybody, and again we'll be using the Q&A. So as I said previously, during that panel session also, if you can post your Q&A and we will monitor that. So I'm going to move on to our first speaker, who is Ray Moynihan, who is going to talk to us about a review of global evidence. Ray is an assistant professor at the Institute for Evidence-Based Healthcare here at Bond University and has a global reputation for tackling the problem of too much medicine. And Ray's talk today is a review of global evidence about the changes in health services utilisation during the COVID-19 pandemic. Ray, over to you.
Thank you very much, Paul, and thank you everyone for attending. It's fantastic to see so many people joining now and joining later. So I'm at Bond University and with the NHMRC funded Wiser Healthcare Network. I'm going to talk today about changes in healthcare utilisation. So the background to this study is that 1 in 3 people suffer from motivational deficiency disorder, or MODD. Most people don't know they have it, and early detection is recommended. So the research question we investigated was, how have rates of diagnoses and treatment of MODD changed during the pandemic? Many people will know that I'm a long-term sufferer of this condition. I was diagnosed early, thankfully, by neurologist Professor Leth Argos quite some time ago now. And we've done a lot of awareness raising since then, including this short YouTube video in which I say that all my life people have called me lazy. Now we know I was sick. But the good news is, of course, that I've only been able to do what I do because of Strivor. And some of you will know that my son similarly has started using this very effective medicine. But look, you're saying enough with the anecdotes, where's the data? Well, here's the data. Contrary to what many of us expected, we've seen large increases in the rates of diagnosis of MODID through the pandemic period up till June. We've just been analysing this data recently. But as you can see, that the medicine prescriptions really ahead, which suggests to us that there is underdiagnosis going on. And that's something we will get to. But look, I'm just the warm-up act. I don't have much time. So now to the serious business of our systematic review. The background was individual studies reporting big reductions. You've probably seen some of these. Great harm to people missing needed care in cancer, heart disease, and elsewhere. But was there any potential benefit for those avoiding unneeded care during the pandemic? Well, a first step to answer that was our systematic review. What's the extent and nature of changes in utilisation during the pandemic? Our PICO is a very simple one. We looked at people using health services. The pandemic period we compared to a comparable period at least a year before, and our outcome was utilisation of health services. We included studies with data from more than one centre. We excluded surveys and modelling. Our primary outcome was change in utilisation. Our secondary outcome was the changes, if any, to the disease severity of people using that health service. A fantastic team worked on this systematic review, including the senior author, Loe Albaconi. And I just want to pay credit to the clinical and consumer co-authors on this systematic review. It was an extraordinary effort, a global team, and a great privilege to work with them. So what were the results? We screened over 3,000 studies. We included 81 studies. For anyone who's conducted a systematic review, you'll get a sense of how enormous that is. Across 20 nations, with reporting of data between February and March 2020. Collectively reporting on around 7 million services, health services during the pandemic, compared to about 11 million or more in the pre-pandemic period. So you can see already there that dramatic change. Heterogeneity in results, statistical and clinical, meant that meta-analysis was not possible. This is available as a preprint. I stress it's not yet been peer-reviewed. It's very unusual to talk about something that's not been peer-reviewed, but we are living in new times. So what did we find? 95% of the study's findings showed a reduction in use. The median change was a reduction of 37%, with a lot of variation around that. And the 9 of the 81 that we considered high quality time trend studies after our risk of bias assessment still showed a reduction of around 37% as a median. And we looked across the board. One of the strengths of this study, visits were down, admissions down, tests down, treatments down, all categories of healthcare service. This is the figure from our paper. You can see enormous variation in the study findings, but that trend in the median there. And of course, it will be fascinating over time to see how that, where that line goes over time. Some examples of the primary studies from our review. In US emergency departments, visits were down 42% in April. This is a big national database, very powerful data, but a 72% reduction for visits by children under 10 years of age in April. Many reasons for this, many of which you will already know, but an extraordinary outcome. Biggest falls for the less acute end of the spectrum, abdominal pain, 66,000 fewer visits per week. Admissions down, this study, weekly admissions in England for acute coronary syndrome, down 40% in late March. They rose back up, but they were still down about 16% in the last week of May. Diagnostics, again, massive reductions. Total imaging volumes across 6 US academic medical centers down 36% in May. DEXA scans down 98% in April and much of May. Therapeutics and preventive care, first childhood doses of MMR vaccine in the UK down 24% in the final week of March compared to the year before, the years before, but that bounces back to a 27% increase in the third week of April. So a small number of findings did report increases, but as I say, the bulk were decreases. Our secondary outcome was the severity of the users of these healthcare services and how that compared to the year before. 60 findings on severity, 33 reported no change in relation to severity, 27 reported larger reductions among people with less severe illness. Unsurprising perhaps, but a interesting finding across many of the studies. Let's have a look at them because there's some very fascinating implications here. Endoscopy down, of course, all around the world, but improvements in the appropriateness of urgent referrals in endoscopy units in a study in Italy. In France, in Paris, emergency department psychiatric presentations, larger reductions for anxiety and stress compared to psychosis. Authors concluding some people may find new strengths and coping strategies during disasters, and perhaps an elevation in resilience. A big German study found a 9% drop in admissions for stroke, but a much bigger drop for admissions for CIA. In northern Italy, at the height of the pandemic, big drops in kids attending ED departments, authors concluding most of the non-relevant pathologies usually seen at our emergency departments have been avoided, freeing resources to provide critical services to patients suffering in genuine need. Multiple studies of acute coronary syndrome admissions, bigger reductions was a pattern in the less severe non-ST segment elevation MIs, the NSTEMIs, compared to the STEMIs. And here's that Lancet study again, looking at weekly admissions to acute hospitals, much more dramatic drops in the NSTEMI. Now, this is obviously going to cause a lot of discussion, is causing a lot of discussion within cardiology and elsewhere, but one observer in JAMA Internal Medicine pointed out that most of these patients would do well in the short to medium term, even if they receive no medical care. Now, I'm sure that's a controversial statement within cardiology, and I'm sure there's a lot of interesting discussion ensuing. But what's happened to services where overuse is well known and uncontroversial? PSA tests, thyroid function tests, inappropriate antibiotics or proton pump inhibitors, knee arthroscopy, hysterectomy. Well, none of the included studies, none of those 81 that met our eligibility criteria focused solely on changes in the use of low-value care. There's a clear need here for more research. Just to finish off the reporting of our systematic review, we think it's one of the first overviews of these studies of changes across all categories of care. It was very efficiently done. It took under a month. And it's using the new 2-week systematic review processes that our institutes developed, and it was a high quality review. The limitations, of course, are the strong possibility of publication bias. Heterogeneity, as we predicted, meant that no meta-analysis was possible, and there are limits to the use of this median statistic that we've reported. Global figures have limited meaning in local settings, and many health systems around the world will have much fresher, up-to-date, locally relevant data. We recommended a range of future research, high-quality time trend analysis of the ongoing changes, including substitution with things like telehealth. Cohort studies to find out what the health impacts of these changes are, both the harms and the potential benefits of avoiding care. Qualitative research, and some is already underway, and research on changes specifically to low-value care and how to maintain those reductions while pulling back lifting up the high-value care. Just to sort of change tack and start to wind up, there's no question that too much medicine is a threat to global health. This is what Lara Gologli from the WHO said a year ago, speaking at this event. A year ago, WHO, of course, a co-sponsor of that event. It's critical we control the overspend, the waste, the iatrogenic harm that's caused by too much medicine, overdiagnosis, and the stretching of disease definitions. The 194 ministries of health with whom WHO works all face this problem. In Australia, a lot of support for and calls for national action too from a range of influential groups. And at the highest level now in our health system, we have people acknowledging overdiagnosis as a problem and calling for action. There is a real opportunity with this crisis to address too much medicine, to redouble our efforts here. A lot already going on, but more can be done. Across the journals from BMJ to the New England Journal, there are calls to use the crisis, to use this opportunity. A big report from the Academy of Medical Royal Colleges in Britain in July, essentially a blueprint for that nation to wind back low-value care, has said the impact of COVID has reinforced the importance of this work. In Australia, one way to take advantage of this opportunity is to set up what we're going to call a Wiser Health Policy Forum. And this will focus on research policy collaborations to really start to wind back harmful waste. One example of what we might focus on is low-value care in private hospitals and vertically integrated corporate GP practices in Australia, where there's a real lack of transparency and lots of work to do. And that will start soon. And of course, Paul's already mentioned this amazing opportunity where we might actually get to see each other next year. Just to conclude, large global reductions in the use of healthcare, bigger reductions for less severe illness. Addressing unmet need remains a key priority along with battling the pandemic. But the crisis may be an opportunity to tackle unneeded care, to focus on what matters most. Let's move fast and fix things with science-informed solidarity. Thank you very much for your time. Happy to take a couple of questions before we move to Professor Duggan.
Okay, thanks very much, Ray. That was great. And we've run a little bit over time, but we still have a few minutes for questions. I'm just going to read some of the ones off the panel. You mentioned as a limitation the publication bias, and Jim has picked up on that and said, surely the people who are very busy at the moment, overwhelmed because of the amount of service they're providing, are too busy to write up their work, and it's those who have been quieter during the pandemic who have actually had the time, because they haven't had to write it up, to report their underutilization of their service because they're sitting around doing nothing.
That's a very, very good point. That's a very good point. And I should stress that we were looking at the non-COVID healthcare utilization. So we did not include studies that reported on the use of tests or treatments for COVID patients. But that's a very good point. And of course, the other aspect of publication bias is if someone looked at their data and found no change from the year before, they might be less inclined to report that rather than finding quite a big reduction.
Great, thanks. And Ray, someone else has asked that those reports are mostly from a single centre, but there may be a spillover effect. So for example, someone's asked about the low levels of mental health disorders presenting to the hospital, but perhaps they're just being diverted to somewhere else like primary care. So you actually need to look more health system wide.
I think that's absolutely another very important point. And interestingly, in those studies, we did, in the 3,000 that we screened, there was very little on telehealth. And we conducted this review in our search strategy in August. It's possible if we renew it, or when we renew that search, we will start to find a lot of reports coming through on telehealth, where of course we'll see big increases in use. And yes, that issue of substitution is an important one.
Okay, and related to that, someone's asked about the inclusion criteria for healthcare utilisation. Did it include admissions, outpatient visits, daycare procedures, etc.?
It did. We were very broad. We were as broad as we could. And as a result, we had to do an enormous amount of work reviewing those studies. But yes, it was very broad. So look, thanks very much for all those questions.
Just one final question, Ray, and that was, were there any examples bucking the trend where, for example, admissions had increased? Someone suggested this for serious eating disorders.
Yeah, look, there were reports. I don't remember any on eating disorders, but there were reports. For example, I used that data showing an increase in some weeks, increase in the vaccination rates over the previous years as they attempted to catch up on the previous deficit. In some studies reported an increase in the use of certain treatments for stroke, for example. So there were isolated cases, and of course in each case there would need to be a lot of local and clinical context to understand what's happening.
Okay, great, thanks. And someone's also asked for a link to the preprint of this, so we'll get that into the Q&A during this session, so it'll appear on the Q&A.
Thanks very much, Paul.
Thanks very much, Ray.
Thank you, everyone.
An applause from everyone.
Thank you.
And the thunder in the background is about to mimic that for us. So we're going to move on to our second speaker for today, and that's Anne Duggan. So Anne, I'll just get you to share your screen for us. Anne is a gastroenterologist and conjoint professor of medicine and public health at the University of Newcastle. She's director of the healthcare variation at the Australian Commission on Safety and Quality in Healthcare, and leads the development of the Australian Atlas of Healthcare Variations series. Anne's talk today is Changes in Australian Healthcare Utilisation, Reflections on What They Mean for Healthcare. Thanks very much, Anne.
Thanks, Paul. It's always a hard act to follow. Oh gosh, I've just forgotten. Ray, yes. For someone with motivational deficiency disorder, is quite industrious. It just shows the medications are working. Now, my reflections are personal reflections, not the reflections of the Commission. But as Paul's pointed out, I've spent some time looking at healthcare utilisation in Australia, working on the atlases of healthcare variation. When COVID hit us, I was working on my clinical day in private practice on the North Shore of Sydney in New South Wales, when on the 25th of March, the National Cabinet said that all non-urgent elective surgery would be suspended to ensure that we had adequate hospital capacity to respond to COVID-19. And of course, back in March, we had no idea which way it would go. So working in the private sector, it was going to hit us at the 1st of April. And limit activity to critical criteria. I've spent my career working in the public sector and was very familiar with how we dealt with budget constraint and resource limitations. But I was curious to see how the private sector, which is a large part of our healthcare system in Australia, which is also funded by the Medical Benefits Scheme, which is government funding, how it would respond, given that all clinicians in private practice are geographically isolated. It was very interesting to see then that when we could do some activity, what came to me was this indication that I could do 25% of my normal endoscopy activity, which just struck me as a strange way to ensure that the population were getting access according to need when we had limited resources. It seemed to me that what you really wanted to be sure was that somehow, that somewhere in the system, they were sure that my 25% that I was going to be doing was of high value and was of higher value than somebody who wasn't getting access for their patients. And it led me then to think about, well, what did happen as a consequence in Australia? And so I thought that if you have limited resources, as we did come April 1, you would hope that those resources would be allocated to people who had critical illness that needed treatment. So cancer being one of those examples. And as we all know, in Australia, lung cancer is the third most common cancer for both men and women. And so I was interested to see what happened to lung cancer related diagnostic procedures. And here you can see the months of the year on the x-axis, and on the y-axis the number of services funded by the MBS, with the dotted line being what happened in 2019, and not too surprising, was a drop come April. Now, that to me marked that we weren't able to look after everybody who you'd expect to be needing a diagnosis. Unclear as to whether people were too frightened to come out of their houses to seek treatment, or whether the system, as I hypothesized, might not be able to tweak itself to be able to ensure that that tip of the iceberg in terms of need was being addressed. This is just that data shown by states of Australia, and you can see New South Wales and Victoria at the top, and you can see a marked decline in April in New South Wales, a marked decline in Victoria because Victoria was hit by COVID much more than us. And again, the question of whether this is due to the system's inability to prioritise or consumers' lack of desire to utilise, or a combination of the two, or what was going on. It made me, because I'm a gastroenterologist, think about what was happening in relation to bowel cancer. Australia has a national bowel cancer screening program based on a fecal occult blood test, a poo test, which then leads you, if you're positive, to have a colonoscopy and then treatment if you have a cancer with a surgeon in general. This table, taken from the first Atlas of Healthcare Variation, which was using AIHW, that Australian Institute of Health and Welfare data, and that's why the date is 2014. I was lazy, I didn't redo it. But the aim of putting this up is to show that, as you all know, with increasing age and across the x-axis of the 5-year age groups, there is a rise in cancers, and there's the rate per 100,000 up on the y-axis. And you can see the dark blue at the top and the light blue is bowel cancer. That's, in Australia, it's the second most common cause of cancer, as compared, in stark contrast, I think, to the rates of gastric and esophageal cancer, which are sitting right down there, no matter what the age group, quite low, but just touching 100 per 100,000 for men once you get to 85. So you would expect then that we'd be using our limited resources and access to endoscopic services to be ensuring that people who might have bowel cancer were getting their diagnosis and treatment. It was interesting to see that the MBS showed that for colonoscopy, a marked decline, and as you can see on the left, from somewhere about 55,000 in April, it dropped to 28,000, and that's colonoscopies without polypectomy, and again, a significant drop for colonoscopies where a polyp was removed. What impact did that have on patients then who were picked up for bowel cancer and then sent on to have their surgery? Well, this is the MBS data on colorectal cancer investigations, surgeries, and you can see the drop in April, May. But Ray's talked about utilisation of resources and decline in utilisation, but I wanted to go down a bit further and see just how much of the use of the resource made sense. So you saw the graph before about where bowel cancer occurs. Well, in April 2020, according to the MBS 3222, which is for colonoscopies for investigation of bowel symptoms and signs, well, we were still doing a lot of colonoscopies for people where the risk of cancer was less. Now, that's not to say there aren't other conditions where it is life-threatening or very urgently needed to have a colonoscopy, but it does raise the question whether there really were high-priority colonoscopies being done right across the system. And if you look at that data, you can see that 18% of the 19,000 colonoscopies for investigation of bowel symptoms and signs were done in people between the age of 15 and 44. It does raise that issue of our capacity to prioritise. If you dig a bit further and say, well, endoscopy units can either be doing gastroscopies or colonoscopies, you can't do two at the same time, so it's an opportunity cost. But it's amazing when you looked at the data for gastroscopies during that critical period, and we were doing a lot. And I pointed out before that esophageal and gastric cancers are quite uncommon. In fact, of the 13,000 gastroscopies, 38% were done in people under age 54, between 50 and 54. And there were 2/3 as many gastroscopies as colonoscopies being done for investigation of symptoms and signs, which really, to me, didn't make sense. So looking just at that snapshot, given the time limits we have, it struck me that what the COVID restrictions have pointed out is that the COVID restrictions on our surgical activity and endoscopy shows that there are limits in our health system's current capacity to triage scarce resources to maximise health outcomes. And it seemed to me that one of the big limitations we have and the barriers to going forward is that the information on pre-test probability and individual and population benefit, which provides a basis for prioritisation of resource use, is neither provided nor collected. But it could be. And I would suggest that if it were, we would have the capacity, both in COVID times and in non-COVID times, and in times going forward with economic restriction and constraints, to better use our resources. Well, how would you do that? it seems to me that the death of the provisional diagnosis is a major factor in this. What happens if we reintroduce the concept of provisional diagnosis as a prerequisite for ordering investigations and being able to book a patient for admission to hospital? Make it also a basis of clinical review meetings. As part of the Atlas of Healthcare Variation, with our national standards now, under the government standard, it is a requirement for health services to provide data to clinicians on variation. But wouldn't that be much more informative if that data not only looked at the rates at which procedures were done, but looked at the indications based on the provisional diagnosis? And of course, if you then tied that up with the audit requirements for continuing professional development for clinicians, that might make it more robust. And what about with recredentialing? Currently, recredentialing to work in public or private, both facilities are funded by the taxpayer. Basically, the requirements are to be of good character, with one of your colleagues saying so, and providing the paperwork. You don't have to demonstrate that you have clinical acumen and you use resources wisely. And perhaps if we did make your diagnostic yield part of that, we may get further. And what about registration renewal being a requirement of that to demonstrate some acumen? And it would strike me that your indemnity insurer may very well become more interested in insuring you if they know that you have a good capacity to a good judgment and only expose patients to risk when you know the benefit exceeds the risk. And of course, if we really had a fantastic health system, we would not only credit, as we do currently, all our health services according to national standards for safety and quality. That's all our public, private hospitals and day surgeries. But maybe there would be a standard for measuring facilities' equity of access based on those bullet points above, demonstrating that that sort of activity is occurring within the facility. I would suggest to you that in Australia we have the capacity to move that step further. We have the National Safety and Quality Health Service Standards, which came out in 2013. As a product of that 1.28, we have this year developed a user guide for review of clinical variation in healthcare, and that is now mandatory to be doing that as part of your health service. But I think there is this is the path to follow, and I think the other cornerstone that we really do need to raise awareness of and remind clinicians of is that we have an obligation to the patient in front of us. But as the Code of Conduct for Doctors in Australia, put out by our medical board, indicates under 7.2.3, in terms of the wise use of healthcare resources, clinicians have an obligation to support the transparent and equitable allocation of healthcare resources. So I think, in summary, looking just at that snapshot of what's happened during COVID has been, I think, an indicator that even when times are tough, we don't currently have the tools to really prioritise in a transparent way, and in a way we can discuss the results and the outcomes, but we do have the capacity to change that for the future. I've only mentioned colonoscopy, but I would recommend to you that if you go to that website, you can look up any Medicare data during the COVID period, Google the item number of interest, and you can put in and see what happened. You may be interested that if you put in arthroscopy, there was a drop of 80% over April, but compared with the previous April period. But don't worry, in June it overshot, possibly to compensate for that lost activity earlier in April. Two other things to look at for information are the MBS data that's put out in their reports. I'd also recommend that you look, if you don't think we have a problem with widespread variation in use of our resources, I would recommend that you look at the data from the atlases, and we're about to publish the 4th atlas. And if you're interested in healthcare variation over diagnosis, underdiagnosis, inappropriate treatment, and really unwarranted variation, then join us next year for the Better Care Everywhere online series where we'll explore what people are doing about healthcare variation. And I will end there.
Thanks very much, Anne. And Anne, can I just ask you to pop your video back on as well for the question period? Got a couple of questions now online, but I just wanted to ask you, I just wondered about follow-up, given your bounce back comment about the arthroscopy. I was wondering about the bounce back with various other things, and the fact that, interestingly, across the states we'll have something of an intervention and control group between Victoria and the rest of the country in the second wave process.
Yeah, I think that's something we really do need to watch, and it'd be very interesting to see what happens in that regard. I think one of the things, though, is that for some things, for example, when we looked at colonoscopy initially with the Atlas, the MBS responded by making changes to the indications for colonoscopy, which puts a bit of a framework around it. But I think for most of these things, given that there isn't a good hard stop to doing things, I think if the system opened up and there is capacity to do it, there is not much resistance in the system, I think, for that to stop, just fill up. It's almost like the capacity being what is the limiting factor. But when you limit the capacity, I don't think we have the tools to rationally prioritise.
Okay, thanks, Anne. One of the questions, someone liked your comment on the pre-test probabilities and the provisional diagnosis, and suggests that pre-test probability is most often not used by clinicians, if ever. Should we tackle medical education about this important topic?
I think what I was trying to sort of say was I think we should do, medical education is an incredibly important cornerstone, but I really think that we need to get it into the way we do business. I find it extraordinary that I can book a patient in for a procedure to a private hospital, which will be, and the procedure will be funded by Medicare, the public funder, but I don't have to say why I'm doing it. And that means that nobody can really question me on my use of resources. Whereas if I said the provisional diagnosis was I thought somebody had gastric cancer, and you could say to me, well, they're 25, they're well, why would you think that? And that's why I think that getting back to provisional diagnosis as a requirement to be able to access the MBS is a very powerful tool to start conversations about, well, tell me about the value of this. Why are you going before me? You know, why is that resource being used?
There's a question too about the differentials in the risk of who was going. So you presented the age distribution during April, but someone's made the comment that the population has been well educated, in fact, to recognise that the young people are at lesser risk of a severe illness than old people, and might that be making the difference to who actually goes along?
I think that would explain why perhaps the older age group isn't bigger. But I suppose my question is, why were we doing, for example, gastroscopies at that rate in young people? What was the burning, urgent clinical indication for doing it? I absolutely take the point that there might have been more people, older people, who just weren't turning up. But it's almost as though you do have to wonder, by doing those younger people, whether in fact there were other older people who did want to turn up but couldn't get on.
Final question is that, or comment really, is that the MBS for several things limits the use of them, like MRI for some conditions, to specific provisional diagnoses, but people don't actually provide those at the moment. And so one of the things that the system needs to do is really insist on that, but we don't.
Yeah, I do think it's extraordinary that we expect accountability across all lots of parts of society, but we've allowed the accountability to drop off. I think the other point is that we're losing great opportunities if we if we're saying to patients that their partner's in their care, we're losing, and we want to educate ourselves by not doing provisional diagnoses and just ordering a test. I think we're losing the opportunity to be much more highly skilled and really making patients part of our care. I mean, the concept of we might do this, I think the patient walks away in the belief that they might have a cancer when they're 25, and the chances are 1 in 100,000. And the tools are there. The AIHW, etc., has tools to be able to give that sort of education. I think that's the way forward.
Okay, we'll look forward to seeing progress on that, Anne. Thanks very much for your presentation. And the virtual applause again, as usual.
Thank you.
Thanks. We'll shift back now to the panel session. So we're now going to have 5 speakers who'll give just a 1 slide and brief presentation of 2 to 3 minutes. I'll just introduce them all to begin with. So our 5 speakers in this session who will then form the panel for the panel discussion are Katie Bell, who's a clinical epidemiologist at the University of Sydney School of Public Health. Kim Sutherland, who's a health services researcher with experience in the performance of measuring and reporting, evaluation and assessment of quality change in healthcare organisations. And she's the Director of the Evidence Generation Dissemination at the Agency for Clinical Innovation in New South Wales. Dr. Megan Keeney, who's the Principal Advisor at the Health Technology Assessment and Device Division at the Australian Government's Department of Health. Jenny Doust, who's a clinical professorial fellow at the Centre for Longitudinal and Life Course Research at the University of Queensland, and also works as a general practitioner in private practice in Brisbane. And Leah Hardiman, who's a consumer representative for over 10 years, and she's the past president of Maternity Choices in Australia. So I'm going to pass over to each of them to speak, and I'll be controlling the slides for this, by the way. But let's begin our first presentation from Katie Bell. Thank you, Katie.
Thanks, Paul. So, hi everyone. I'm going to very briefly present the Australian mortality trend so far for 2020. This slide shows the weekly number of doctor-certified deaths published so far by the Australian Bureau of Statistics. Along the x-axis are the consecutive weeks from January to the end of July. On the left y-axis are the total number of deaths each week, including COVID and non-COVID deaths. On the right y-axis are the number of new SARS-CoV-2 infections diagnosed each week. The dark blue line shows the number of new infections, and we can see the increase from February to the peak of the first wave at the end of March, a decline from April through to June, and then an increase again with the second wave in Victoria, which peaked in early August just after the time on this graph. The average weekly deaths for 2015 to 2019 are shown by the orange line, and the minimum and maximum number of deaths across these 5 years by the light blue band. And then finally, the weekly deaths in 2020 are shown by the dark red line. So I think the data on this slide show a story in 2 parts. The first part of the story begins in January and ends mid-May, where there were more deaths than expected, with a total of 2,257 excess deaths by the 12th of May. Many of these excess deaths are deaths in people who were known to have COVID-19. There were also probably a small number of people who died from COVID-19, but their diagnosis was missed because of undertesting early on in the epidemic. And there is also an excess of some non-COVID causes of death, which might be partly due to the bushfires back at the start of the year, and then to decreased access to necessary healthcare as the pandemic unfolded. The second part of the story is from mid-May to the end of July, where there were fewer deaths than expected, with 1,969 fewer deaths for these 2 months. A large part of this deficit is due to fewer deaths from influenza and other non-SARS respiratory infections, as an important co-benefit of measures introduced to limit the spread of the pandemic. There may also be an offset in deaths in more recent months because some people died earlier than they otherwise would have done in 2020. But it is possible that at least some lives were saved because some people avoided unnecessary tests, diagnoses, and treatments, and the risk of harm from those interventions which outweighed the potential for benefit. Thanks.
Thanks very much, Katie. And just a reminder to everyone, if you could please, as we go along, put your questions, type them into the Q&A so that we can monitor them as I go. We'll come back to those during the discussion session. I'm now going to pass on to Kim Sutherland, who's going to talk to us about tracking a pandemic for the New South Wales Critical Intelligence Unit. Kim.
Oh, good afternoon, everybody. Can you hear me okay?
Yes, you're fine.
Perfect. Yes, thanks very much. I'm going to talk about the Critical Intelligence Unit, and I'm just showing a broad organisational structure. This is a paper that's coming out in the next week or two in NEJM Catalyst, which really describes the New South Wales response to COVID and the Critical Intelligence Unit. We're really focusing in the unit on both the direct and indirect impacts of COVID. So we produce a number of products, some daily with epidemiological and critical input data that goes directly to the Secretary who's taken on the role of Incident Controller for COVID-19. We produce a risk assessment that sets the level of risk, whether it's green, amber or red for the state, and that determines the level of PPE and recommendations about operations in hospitals, but also broader community spread, so reflecting that risk of transmission. We also produce a number of evidence checks, evidence reviews, and we produce a lot of data, bringing together data in an integrated way. So yes, we look at direct impacts of COVID-19, but we've been very fortunate with low numbers, of course, in New South Wales. And so we're also interested in those indirect impacts. And some of the patterns that Ray was describing as he'd found in his systematic review or his team's systematic review, we certainly found replicated in New South Wales. And we were able to then look across the whole of the system. We pulled together researchers and data from a range of different repositories and organisations and branches, and really gave us a broad view of those indirect impacts in terms of utilisation. But we went a little bit further. Rather than just looking at the quantitative data that we had available, we also did some crowdsourcing to ask clinicians about what should we be tracking as the consequence of some of that missed care or foregone care, whether they're positive or negative. And also we held a number of workshops with consumers and with Aboriginal groups to really see what their perspective on the indirect impact of COVID was. And so we're pulling all that information together. And I feel that pulling together of experiential evidence, research evidence, because we look at the what's been published in the literature, which Ray so eloquently described as pulling together all of those studies of the indirect impacts of COVID. So that's informing our work as well. So experiential, research evidence and quantitative evidence is what we pull together. And we're just about to publish that, the New South Wales experience in public health research and practice in the coming weeks. I'm just looking at the proofs this week. The other thing that we're very interested in is the opportunities for the new normal, and that's something that the Critical Intelligence Unit has been very interested in exploring. How can we take the opportunity that's presented by COVID to reshape healthcare, particularly in New South Wales? And one of the themes that's definitely come out is really that push for greater value for reducing unnecessary care. We do feel that there is an absolute opportunity for us to grasp And if we don't take it soon, it will dissipate. We did see, similar to other speakers saying, we've seen a decrease in activity, particularly in April and May. We saw it with grommets, we saw it with arthroscopy, but we do see that things trend upwards again very quickly. You know, if the capacity's there, it gets filled. So we have a limited window of opportunity to try and reshape practice. And there are a number of themes that are coming out of that new normal. Around vulnerable populations, around protecting our workforce, but certainly value is a key theme that's been coming out of that work. So that's it.
Okay, thanks very much, Kim. That's excellent. And just a reminder, we're getting a couple of questions coming through on the Q&A, but please add your Q&A questions there and we'll come back to them during the discussion session. And I'm now going to pass on to Dr. Megan Keeney to talk to us about the national perspective. Thanks, Megan.
Hi, Paul. I'm sorry for being late, and I'm sorry I actually missed most of Ray's talk. I'm here today standing in for Brendan Murphy, the Secretary of the Department, who I'm sure all of you would know now as the father of the nation. But I'm trying to channel Brendan in these few remarks. So really, I just wanted to talk about two aspects of the landscape where we've seen some changes recently, motivated by COVID, if you like, and really COVID has accelerated some reforms and evolving changes that were already underway. And in particular, we think that it certainly paved the way to a more integrated system and improved cooperation between the Commonwealth and the states. You only have to recognise the examples of the AHPPC, the meeting of the Committee of Chief Health Officers around the nation that was meeting daily during the height of the crisis and is still meeting, I think, more than once a week. There are a whole body of advisory committees that were made up of representatives from the jurisdictions and the Commonwealth working together to get to the point that the envious point that we're at with the management of COVID in Australia. But also in the background there were already reforms underway which are important and reflect the fact that we have been trying to move to a more integrated system for quite some time. And during the middle of COVID, of course, we had the commencement of the 2025 National Health Reform Agreement. That's the agreement that sets out funding as between the Commonwealth and the states for state-provided services. And in that, there's a whole reform agenda which speaks to cooperation between the Commonwealth and states about new models of care, new ways of funding things and delivering an integrated approach to healthcare generally. I wanted to pick out one aspect because it's relevant to the work that I do and many of you do around the table, which is there's a specific commitment in there to nationally cohesive health technology assessment. So we are already seeing cooperative arrangements around the assessment of particularly high-cost therapies, where that work is done on behalf of the states and the Commonwealth, and assessments are being done by MSAC to deliver that advice to the jurisdictions as well as the Commonwealth. And that's really something that we've never seen before. So that's my first example of COVID impacts and how they're helping our system. The second one, of course, is the move to digitisation of health, and telehealth, which has been sitting there for some years, funded through the MBS, was certainly accelerated during COVID. It's probably been inevitable that we would move to more broader use of telehealth within the MBS system. Although until this crisis came along, of course, the reform in that area was really around, yes, let's use telehealth, but try to move away from fee-for-service arrangements and fund it perhaps through capitated payments and the like. Instead, we have MBS-funded telehealth that has proved to be enormously popular and enormously valuable during this period. And I've presented some data there for the most recent quarter, the September quarter, letting you know the uptake of telehealth. So phone consultations by GPs with patients was approximately 30% of all GP attendances for that quarter. And video has proved not to be terribly popular at all. In terms of total numbers for that quarter, our service numbers are about 2% more than they were for the same quarter last year, which is fairly average, if you like, although of course it was also in a period where utilisation in Victoria was probably down relative to the norm. So the point of that is we really don't get an understanding yet as to whether telephonic consultations are really substituting for face-to-face or whether they are additional services, and it's probably going to be a mixed picture. And of course that leads into considerations of quality of care issues and low value care, and whether we're now supplementing services that may not be required or were else certainly provided formally. You know, watch and wait, I suppose. The data might tell us a bit more as we go on, but I think it's pretty clear that telehealth and digitisation of health is here to stay. So thanks.
Great, thanks very much, Megan. So we're now going to move on to two presentations that are from the coalface, with Jenny Doust talking from the GP perspective and Leah talking from the consumer's perspective. So Jenny, can I hand over to you? And just remember to keep those questions in the Q&A. Jenny, are you unmuted?
Okay, now I'm unmuted. That's the slogan for the year, isn't it? Unmute. So it's very delightful to be able to talk to you about this work and what's really been happening at the coalface in general practice. So I work as a GP in the suburbs in Brisbane. And as you're probably aware, Queensland's been one of the best places in the world to be during the pandemic. We've only had 279 community-acquired cases in the whole of the state, and the state's about 5.5 million people. We've had one case diagnosed in our clinic, and that was fortunately all managed by phone, so thank you to the people who organised telehealth. The biggest impact for us has been what's happened to the face-to-face visits and then that substitution with telehealth. So similar to what Ray was saying in his review, in that last week of March and then into April, we had about a 30 to 40% drop in patients. So if you look at the pale orange line, that's the sort of standard GP visits billed in Queensland, and you can see that big drop off in April. Same thing happened in Victoria, and then you can see when that second wave happened in Victoria, again the face-to-face visits fell even further, whereas in Queensland they came back to somewhat closer to normal. But the number of sort of visits overall was made up for by the fact that we had these telehealth items. So in fact, the number of kind of consultations that were happening overall probably didn't go down a great deal. What those numbers don't show is how much what we're doing has changed. So a very significant proportion of the telehealth visits have been people where we've had to, people with mild symptoms that could potentially be COVID-19, they all have to get tested. So a lot of the telehealth consultations are organising COVID-19 testing. The thing that has just completely fallen away is the number of people who come in for respiratory tract infections, because A, they have to get a COVID-19 test first, but also the social distancing has been just incredibly effective at removing those respiratory tract infections circulating in the community. So if you look at the second graph, you can see that red line, that's the number of influenza notifications in 2020. And in February and March, that was going up. We had a sort of a mini pandemic happening in the local high schools in our state, near our clinic. And then you can see once the social distancing started in mid-March, it just dropped away to zero. So the pandemic has been incredibly effective. All the measures that we've been doing have been incredibly effective in terms of getting rid of lots of respiratory tract infections. We've had to do a lot of talking to people to reassure them to come in for visits. So you can see this message to our doctor group from one of the doctors, where we've had to talk to patients saying that it is safe to come in. There was a lot of anxiety from patients, especially early on in the pandemic. And also that they for some reason they believed that we were actually incredibly busy, even though we were actually quite quiet, really. There's certainly been a lot of stress and anxiety, and that's mostly been a bit about the pandemic itself, but because we've had so little community transmission in Queensland it's been more about people whose livelihoods have just dropped away. There's been a lot of change, a lot of good changes that have come out of this. So things like the telehealth, smart referrals, which weren't pandemic related, but certainly have improved the systems that Anne was talking about, better methods for electronic prescribing. But really, it's been quite a stressful experience, even in Brisbane. And it's really made me realise how poor health literacy is and how much even the traditional media wasn't necessarily helping us in a lot of cases. So thank you.
Thanks very much, Jenny. So for our final speaker, we have Leah Hardiman, and Leah's going to talk to us about the health consumer and COVID-19. Leah.
Thank you. Good afternoon, and thanks for having me here today. COVID-19 has presented a challenging and somewhat confusing time for consumers. COVID has led to an increase in consumer engagement throughout Australia. Health services, researchers and policymakers have sought community advice to enable them to design their work to meet the needs of their target audience and community. Perhaps the most significant change to delivery of healthcare, and we've spoken about this a bit today already, is the significant increase in telehealth services. It has had, I suspect that a deeper dive is required to actually for us to determine what is best with regards to going forward with telehealth. There has been mixed reviews from consumers. An interesting response to the pandemic was the suspension of non-urgent elective surgeries and screening clinics such as breast screen. Another change we saw in Australia was to the diagnostic procedure of gestational diabetes. It was a change that was welcomed by women and also supported by evidence, which is always important. Increased consumer engagement. Consumer advisory committees have been developed at every level of government during COVID to provide expertise on health services could best be delivered to meet the needs of the community. It was interesting to see also the rapid change to MBS item numbers or additional item numbers, and consumers now able to get referrals and scripts via telehealth and via email. There was significant reorientation in some areas of health services. We were looked hospital in the home services and models of care became available, previously had not been. One locally on the Gold Coast was women who had previously been long stay antenates, so they're pregnant and they've got risk factors that require them to stay in hospital. The hospital and health service was able to keep those women at home and provide care for them at home. And we saw an increase in care in the community, trying to keep consumers out of hospital. With regards to and so that's probably an innovative model of care, and also there's a plethora of research projects and proposals that came along, and it was really good to see that consumers were involved in that, and they were really seeking their advice as to what's going to matter the most for us. And how can we change things? I mean, co-designing research and health services with consumers is what I think is really important. Engage with them at the beginning. People with lived experience offer a plethora of information that you may not otherwise have access to. And this will also ensure that the work you are doing will have the impact that you intended it for it to have. Develop rapport and collegiality with consumer representatives. This will be a relationship based on trust, as healthcare always is. I guess I look at this pandemic and try to be a bit pragmatic about it, and I think other people have mentioned this as well. What good can actually come of this? There is potential for this crisis to act as a reset button and a chance for us to do better. And as Ray said when he finished off, focus on what matters most. Thank you, Paul.
Thanks very much, Leah. And And can I get all of the panel now to turn on both their microphones and their video? We'll come to the panel discussion section now, drawing on all the lessons from the different perspectives that we've just heard about. So I'm actually going to stop the screen share there, and we should get the videos back up. And we've got a few questions that have come up now. Katie, you actually got quite a few. And one of them was that you gave 3 hypotheses about the decrease in deaths from the May to August period. How do you think we might untangle which of those hypotheses is correct?
So I did have some other slides that I could have presented that might have helped with that, but in 2 minutes could only present one slide. So we do also have provisional death data for some cause of death groups. And one of those, for example, is respiratory cause of death that doesn't include COVID-19. And that clearly shows that there's a real drop in respiratory deaths. So all types of respiratory deaths, it's like not just influenza, but also chronic lung disease, but mortality may have been also affected by the measures to spread of infectious respiratory disease. So that's one thing, is that it does seem quite clear. And then there was the data that Jetty showed in her slide and other places showing that we really have not seen much influenza this year. So it seems like we can triangulate reasonably well to show that there's definitely less deaths from non-SARS respiratory infections. In terms of trying to look at the last of those hypotheses about whether there might have been some lives saved from avoiding low-value care, and I think that Kirsten's question also sort of was asking about that. I think, so this is also, I guess, what Ray's presentation was at the end, said it would be good to do some studies to see where there has been reductions in low value care and then what have been the health outcomes with that. And I think that actually countries like Australia and New Zealand and other countries in Asia where there has been reasonable control of the SARS-CoV-2, potentially these are the places where we might be able to get some data out of these natural experiments of reductions in healthcare, because there might be proportionately more reduction in the low value care rather than the sort of urgent emergency care that that is necessary. So for example, on that point, a surprising finding to me when I was looking at the cause of death data is that the deaths from ischemic heart disease have been fewer than expected right throughout the whole year, right from January, but become more in the later months. And part of that is that's on the background of a decreasing trend in recent years, and also the reduction in influenza will have a flow-on consequence to reduce people dying of ischemic heart disease. But it will be interesting to look at other data to see what the rates of potentially low value care for cardiac interventions, like revascularization of stable ischemic heart disease, if that has dropped, and if there's sort of regional variation that we can have some sort of control. So I better stop talking so someone else can.
Okay, thanks very much, Katie. And I think it's going to be very interesting to look at what are the things that we've done during the pandemic we can retain. That drop in the flu rates is really quite dramatic, and we probably can't ever achieve that again, but we can certainly achieve some sort of reduction in the annual flu rates as well as other respiratory infections. Megan, there's a couple of questions for you. One was about how do we know about the telehealth collected in Australia generally? Is that part of the administrative system? And can we identify any difference between urban and rural practices within that?
So thanks, Paul. So how do we know? Some of the other speakers have presented MBS data. So you know, Department of Human Services collects the data, and some of it is publicly released, and it's pretty detailed, the publicly released data. But we can then also, obviously, within the department or other people with permission, can cut the data any way you like. So it can definitely be, you can definitely look at patterns according to patient demographics or the like. And no doubt that will be part of the continuing analysis to see how this program is tracking and how it should go forward.
Right, thanks.
Can I just jump in there? Because I think the MBS is part of the picture, but also there's telehealth coming out of the state systems, and that's not necessarily captured in that MBS data. So certainly in New South Wales, we're trying to capture some of that, how people are getting that telehealth from, rather than coming into hospital or into the clinics.
Yep, perfectly agree.
Great, thanks, Kim. We'll look forward to seeing that. A question for Jenny, which is, what were the major gaps in patients or public understanding or knowledge that you saw from the patients you were seeing?
So there were several, but I guess the one that really struck me was the one where patients had they seemed to think that if they had a COVID-19 test at one point, that somehow protected them from getting COVID-19 for weeks. And in fact, even Elon Musk tweeted something about this fairly recently, how he'd had 2 negatives and then he'd had 2 positives. How could that possibly be? And he just, you're Elon Musk, don't you understand this? But it was just so common, and people not understanding about false negatives and false positives. It was just staggering how much that that was actually a big problem, trying to explain that to people.
Right, that's very interesting, Jenny. Given a lot of the surveys showed that the population picked up pretty well and pretty quickly on what the COVID symptoms were and what they had to do. So, but that left room for a lot of misunderstandings as well, it seemed.
Yeah, and I think one of the things we probably got better at going through the pandemic was what to tell patients once they had a test back. So even if you had a negative test and you were high risk, that you still had to isolate, you know, those sorts of things.
Yes, of course. A comment about video versus telephone consultations that I think a couple of people here could comment on is that the video health was much better than telephone consults. This is from a neurologist who said it's so much more can be done with both the audio and the visual information than with audio alone. Jenny, I might start with you because you were actually a personal experience, and then Megan and Kim might like to come in on this.
Yeah, we really wanted to do video telehealth consultations, but we just did not have the infrastructure to support it. And, you know, and you'd set things up and then the person at the other end wouldn't have the right equipment. So, and I think until you've got the kind of roadway and the freeways and those sorts of things, it's just so much easier to do it by phone. If people, it's not so much that the clinic didn't have the infrastructure. We had like 6 different versions of video health systems, but it just was too difficult with the patients.
So Paul, Megan, you know, so the long-standing telehealth program that enabled rural patients to telehealth to specialists, that required that the consultations be provided through video rather than telephone. I mean, I wasn't there in the policy design of this telehealth program during COVID, but I think, you know, the very reasons that Jenny has just remarked upon, you know, drove the decision that, you know, consultations could be telephonic as well as video. You know, whether there's any difference in terms of the outcomes for patients between the two, I don't know whether there is any evidence either way, but I suppose it would be interesting. But obviously they're much easier to use telephone consultations rather than video.
I think that's a really important point, and I know that health services researchers, we've just recently had a roundtable in New South Wales around what we should be focusing our research on, and one of the key issues is what is the appropriate modality for different types. When should we have face-to-face? When is telephone okay? When is video okay? Because I don't think it's well articulated, or we don't understand it all that well yet, and this is really an opportunity for us to dig into that a bit more. It's really an important issue. Certainly the predominant mode was by telephone that we've seen this year.
And Leah, you're unmuted. Did you have a?
And that's where I spoke about doing a deeper dive. I don't think there's a one-stop answer for this about what's going to be the best. It's going to have to be driven by what's available in the community and responded to quite individually, I would say. It would be nice to just develop something that everyone can use, but we know regional, rural and remote areas can have more difficulty accessing those services as well. But interestingly, the data that we saw in Queensland with regards to maternity services being delivered by video and telephone when they couldn't be done face-to-face was that the regional and rural women liked it because they didn't have to travel, because the travel can be quite significant for them to attend an appointment. So it really does need to be looked at a lot. And to have consumers talking to you about that, of course.
Thanks, Leah. And so we've got someone from Canada where I calculate that it's currently 1 a.m. So I think we should prioritise their question, asking about whether anyone knows about whether telehealth has been driving increase or decrease tests per person.
It's Megan here. I don't know the answer, but that's actually something that MBS data could tell you. Because okay. MBS data could actually match a particular type of consultation to the number of pathology services that were generated if somebody wants to do that study.
Okay, we'll note of that, Megan.
Except, Paul, remember the old coning problem. We've still got the old coning problem. Yes.
So there was about a 40% drop in pathology ordering in April as well. So we certainly weren't doing a lot of pathology test ordering via phone consultations, and by a very large proportion of those phone consultations were to order COVID-19 tests themselves. So, but yeah, I suspect, I haven't looked at the MBS items for like the common pathology tests, but a lot of them certainly went down as well.
Okay.
And you have to wonder whether there was any change to anyone if they didn't have a 9 study or a TFT done.
Exactly, exactly.
Yes.
I think that's an interesting issue. That's something that we're also kind of exploring, is this idea of inelastic demand. And do we get a sense from when we had the slowdown, what are the things that were absolutely essential and that they're the things that is there a benchmark that we can set, a line that we can set and say, this looks like the inelastic demand for this kind of condition or this group of patients? And then we would start to be seeing a bit more of over-treatment and over-diagnosis once we had a better sense of that.
Yeah. So we have the opportunity now to look at those things. So Sharon Micken has asked about what research and evaluation about these benefits and challenges of telehealth is being done and how that might inform future policy and practice. And Megan and Kim, I think that's probably a question for you two at the moment.
Can I pass to Kim? I'm embarrassed to say that I can't give you an answer about that, Paul. So I'd like to think that my colleagues in the Medical Benefits Division are doing such. I mean, they'd be doing some number crunching, but from a departmental, operational program level, and trying to work out what should happen next. In the current items, I think they still have an end date of 31 March next year, and how they might be continued. But as to some more robust research, I'll leave that to someone else to talk about, I think.
Okay. Well, I hope it's going on at warp speed at the moment.
Certainly in New South Wales, there's a great deal of interest. There's a real push. There's been a real investment in telehealth in virtual care. There's a virtual care accelerator, and we are certainly doing evaluation of that. But also, as I said, we've started to really engage with the universities in the research sector to get a better sense of the appropriateness and the real benefit and the impact of using more virtual care and telehealth. So early days, but certainly it's a strategic imperative for New South Wales Health to really capitalise on this and make sure that we're using virtual care appropriately for the right patients and for the right reasons.
Okay. Thanks, Kim. And someone's noted that video health also depends on the patient's skill at IT and bandwidth. I think that's an important point that probably is worthy of investigation as well. It reminds me of the surgical problem of the learning curve, that in part of this there's a learning curve and a setup curve as well, as we were hearing from Jenny earlier on. We don't have any more questions in the Q&A, so I'm just going to, we've got a little bit of time. I just wanted to ask if any of the panel had any final remarks that they wanted to make before we close off.
Is that Megan disappearing? It's just one note of caution, which is that there've been very noisy advocates bringing back some of the things that had been improvements during the pandemic. So already one of the hospitals in Brisbane has brought back the old criteria for gestational diabetes. So I think we do really have to kind of strike while we can.
Okay, thanks.
Could I just jump in and ask, I mean, I have to pick up on Kim's amazing comment about the need to grasp this opportunity, the crisis as opportunity to focus on what matters most. I think it's a theme that's emerging from a lot of these discussions. Kim, do you see any way forward, any way of taking that forward? It's a big kind of reform aspiration. What might be the next steps towards that?
Well, for us, I mean, I have a kind of a view of just the state in New South Wales, but I do think there is increasing policy interest in grasping this opportunity, particularly in surgery. So we have a surgical action plan, and part of that is to maybe starting to do some of the things that Anne was talking about this diagnosis, for things that there isn't a good evidence base, that we need some way of adjudicating on the appropriateness and getting people used to having that more transparency looked at. I think that a lot of this is how you organise your healthcare. So as I say, in New South Wales, we're focusing particularly in particular areas. It'd be very interesting to see how that differs across the states of Australia and what's actually happening at a national level as well, and internationally, of course.
Thanks, Kim.
Any other final comments from Anne, Katie, Leah?
I was just going to probably say some work that it is happening and I'd like to see develop more is PROMs and PREMs, which is the patient-reported outcome measures and the patient-reported experience measures. And I know there's some work also going on here in Queensland with regards to non-admitted reform. So it's about keeping people out of tertiary facilities and actually providing care in the community and GPs with special interests. So I think that there is a great opportunity for people to actually not be in large tertiary hospitals going forward. That's my final comment. Thanks.
And so I just had a final thought about the discussion of the telehealth, that we haven't mentioned the important environmental co-benefits of avoiding driving in for clinic, and that actually part of the reimagining of healthcare can be to have a greener healthcare as well as one that delivers high value. Thanks.
Okay, thanks. And Anne, did you have any final comments? No. So I'm sorry, there are several other questions, but that had come in a bit late, so I hadn't caught them. But we'll post all of those questions. But there's some interesting questions about doctors' ability to diagnose over video consultation or phone consultation, which I think is a crucial piece of evidence to look at. Jan Donovan's asked that we include qualitative research of the consumers' perspectives, and that we need to look at the specialists as well as the primary care, which I think has been the focus of most of the discussion today. But there's been increase in specialists, as you'll be aware, Kim, telephone consultations as well. Anne.
I'm sorry, but Paul, it took too long to unmute. I do think that the importance of non-verbal cues is very important. As a specialist, I find phone consultations are very difficult because you just don't get to see the patient's reaction to what you're saying. I think we need to recognise that, and of course the importance of clinical examination at times, particularly the first. A follow-ups is different, but I think we really do need to do that analysis overall.
Yeah, no, good point, Anne. Thank you very much. And thank you all to both our speakers and all of our panelists and everyone who attended and posted questions. It's been a fascinating session with a whole lot of new issues for our research agenda to take up for Wiser Healthcare and others. And we'll be getting in touch with you, Megan and Kim and others, about those research questions. Something that struck me particularly in this whole session was the idea of the reset button, I think was the term that Leah had used for this, that there's a real opportunity here to both learn, but also to maintain what are the good changes, such as the increase in appropriate telehealth. There's been some good prioritisation, but as we heard from Anne, that prioritisation process has been partial and with a lack of complete information. There's been some decreases in unnecessary care, but we also heard there were some examples of increased unnecessary care, such as the hospital in the home being facilitated via the pandemic process as well. And I think that mix of positive and negative changes we need to learn from rapidly and embed the ones that are good and try and keep away the ones that were not so good. And I wish you all luck in implementing all of those things and researching them, and look forward to seeing you in Calgary next year.
Thanks, Paul.
Thank you.
Thanks, everyone.
Thank you.
Thanks, everyone.
Bye.
Bye.